without further ado, I will hand it off to my colleague, Dr. Jennifer Hall-Lande. She is a researcher and psychologist at the Institute of Community Integration and the Masonic Institute for the Developing Brain at the University of Minnesota. Her work focuses on early signs of developmental delays and early identification of developmental disabilities. Dr. Hall-Lande leads multiple disability-focused studies, including the Minnesota Autism and Developmental Disabilities Monitoring Network. As a note, just for today's presentation, Dr. Hall-Lande is actually currently traveling, is out of the state, and just presented at a national conference, which is awesome. But she also might need to step away once or twice throughout our time here, just to get a drink of water or something, because she's been talking the whole day. So with all of that said, please join me in welcoming Dr. Jennifer Hall-Lande.
Thank you, Drake, for that nice introduction. And thank you to all of you for being here today. I know it's at the end of your day, and it just really means a lot to all of us that you're here, and we will learn together. And also, just a quick overview, I am a psychologist. I work primarily with children around early identification of neurodevelopmental disabilities and developmental delays, such as autism. But today we're going to talk about neonatal abstinence syndrome, or what we'll call more recently, the name that we're using is neonatal opioid withdrawal syndrome. But we're going to talk a little bit about an echo model first before we go into that. And Drake is right. Not only have I been speaking today, but I am at the tail end of a cold. And all of you are probably lucky that you're not in the same room with me. I may have to pause and get a drink of some warm liquid. Here's a tip. I'm already going to start with the tips. One of my colleagues who does a lot of radio programming says, drink a warm beverage when your voice is getting a little gravelly, or if you're about to possibly cough, and that will help sort of your throat, soothe your throat. So I have a tea right here that I may be drinking, but I'm determined to be with all of you. Good news, you may get done a little early because I probably will move through things at a brisk pace. All right, next slide, Drake. So again, as Drake said, this is called Minnesota Project Scope. And we'll try not to devolve into acronyms, but what SCOPE stands for is Supporting Children of the Opioid Epidemic. We're going to focus on Neonatal Abstinence Syndrome, or NAS, or the more recent term that we use, which is a mouthful, Neonatal Opioid Withdrawal Syndrome. We're a community of early intervention providers supporting children and families. And we're going to use the ECHO virtual training model that originally started in medicine. I'm just going to give you a quick overview of it. Next slide, please. And I hear a dog out there. I love dogs. I'm a dog and cat lover. Welcome to the dogs that are here today, and cats. The joys of Zoom, right? So what does ECHO stand for? Again, I know many of you work in special education. You have your share of acronyms. So I'm going to try my best to spell out everyone today. What ECHO stands for, if you hear us saying this, and it's actually a really neat model. It stands for Extension for Community Health Outcomes. Our goal is to promote health equity, share knowledge and expertise, reduce disparities, increase access, provide healthcare without barriers, and really bridge healthcare, clinical care, and educational settings. What we're developing here today, and I'm so happy to have all of you, is a community of practice around neonatal abstinence syndrome. And we're going to learn together. I'm the speaker today, but we will have many other wonderful speakers, some of whom are from the medical world. Again, there is that bridge from medicine to education, as well as other various sectors. I want to say one thing about the ECHO model. It probably doesn't seem as revolutionary today in this world poster. We're still sort of in the pandemic. Zoom, we use Zoom, right? Well, ECHO developed well before Zoom through teleconferencing. And what it was started by a doctor in New Mexico. His name is escaping me. If Drake can remember it, he can put it in the chat, but I know you're doing other things, Drake. He was a specialist in liver disease. He was in New Mexico, centered around the university. And it's a sad story that he continually saw people with advanced stage liver disease. And he knew if he could just give training to their primary or general care providers, he could catch the disease early. So he started doing ECHO trainings for healthcare providers around his state so they could learn the early signs of liver failure. At that time, it was revolutionary. It was revolutionary to reach people. His mantra, which I think is interesting, is that knowledge needs to be shared. Knowledge should not just be in the domain of a university campus or large cities, or an area where you're lucky enough to have a good clinical system, that it is our role to take our knowledge and share it, but also it's our role bidirectionally to learn from everyone out in the field as well. So it's a bidirectional model, and you'll see that you'll have chances to share your knowledge and experiences with us. So again, the 4 key components: technology to leverage scarce resources. We use best practices, including the most advanced technology, to reduce disparities. We'll always do, in the medical world, they call it a case study, but we're going to call it a family story, where we share a family story that involves opioid use. And we're going to talk through the lens of our knowledge and expertise and your knowledge and expertise of how we would support that family. And we always use data to monitor outcomes. Drake will be sending you a survey and want to get your feedback. So that's part of the data, and we want to always be improving and hearing from you what you need. Next slide, please. So this is session 1 featuring me. I'll be talking about developmental monitoring, child development, and early intervention. Our goal today was to really ground you in some of the basic tenets of neonatal abstinence syndrome. We're hearing from a lot of early intervention providers. You are seeing children who've been prenatally exposed, or who are also dealing with addiction in their family. It may be opioids, it may be another substance. And really, can we have some tools to better understand and how to work and support these children and their families? So mine is a really general overview. Next week, we will have Dr. Fran Precker, who works in, she's not a neonatologist, right, Drake? But she works in the field working with babies that have been exposed in the nursery, right in the hospital setting. So that will be a great one as well. We're going to talk about ACEs. And we also have several about social determinants of health. Just take a look. Please come to everyone. We love getting to know you across all of the sessions. Next slide, please. And I do apologize for my voice. I sound a bit like a frog today, but hopefully I will be able to make it through. So I am going to get started. I'm probably going to talk as long as my voice will hold up, which is probably going to be about half an hour. Then we will present a family story via video. And then we will have breakout groups and closing remarks. I anticipate I will be getting you out of here early, and we'll have a good discussion and a good presentation. All right, next slide, please. Keep an eye on time too. Okay, so the title of my presentation is Child Development and Opioid Exposure. Next slide, Drake. So I want to ground it a little bit in our current context around opioids. The opioids are considered an epidemic. The opioid crisis in America is considered, let's see, a public health emergency. Approximately, and a lot of these numbers I will tell you are pre-pandemic. We need to update these, and all of the signs that we've heard is this has only increased during the pandemic. We think about the amount of isolation, mental health issues. But what we knew pre-pandemic was about 11.1 million Americans misused prescription meds. A little under about 47,872 deaths from unintentional opioid overdose per year. When you really think about that, 2.6 million had opioid use disorder. Use of heroin and pain medications by women nearly doubled since 2009. And so we think of that, many women of childbearing age. Delivery records indicate quadrupling of opioid use disorder since 1999. So it certainly is an epidemic that we need to pay attention to. Next slide. So I went on a quest to find a good video that was good enough to sort of give you a basic overview of how opioids work in the brain. It's probably not the world's best video, but it was the best I could find. And it gives a nice, it's about a minute long, short overview of the sort of mechanisms and how opioids affect the brain. And I hope the sound's okay. Give us a thumbs up if it is. Drake is going to play it. He's just getting it set up. We want to make sure that it doesn't go too quickly.
What are opioids?
There we go.
Opioid is the catch-all term used to refer to a class of drugs called narcotics. Narcotics are used to reduce pain. They can also be used illicitly to create a sense of euphoria or high. Opioids are either synthetically manufactured or derived from the opium poppy plant. Prescription opioids are used to treat moderate to severe pain, such as post-surgery pain, cancer, dental pain, or sports injuries. Names of prescription opioids include oxycodone, brand name OxyContin, hydrocodone, brand name Vicodin, morphine, and methadone. Fentanyl falls into this category too, but it is also made and distributed illegally. Heroin is the main illicit opiate. Opioids, particularly fentanyl, are potent and dangerous. They carry a serious risk of addiction, misuse, overdose, and even death. Opioid overdose can be reversed if the opioid reversal drug naloxone is administered in time. Opioids work by affecting opioid receptors in the brain and nervous system. They work by sending messages to the brain that block the perception of pain and release large amounts of the chemical dopamine. Dopamine creates a sense of calm and euphoria. This sense of calm and pleasure can reinforce the desire to use opioids again, even when the person is not experiencing pain. When a person uses opioids recreationally, this is called misuse. Opioid misuse can lead to harmful side effects, such as addiction, slowed breathing, cessation of breathing, drowsiness, overdose, or even death. For more information, check out these sources or visit us online at wickedhealth.com.
Thanks, Drake. So it was a nice quick overview of how opioids react in the brain. How many of you, so a lot of those have some of the common opioids. I mean, it talked about heroin, it talked about fentanyl, it talked about oxycodone. Those are some of the, what we're going to be talking about, some of the commonly used opioids that we're seeing. So again, a little more around pregnancy and opioid use. Opioid use has increased more than 4 times in pregnant women since 2010. About 7% of women report using prescription opioid pain relievers during pregnancy. Of those, 1 in 5 reported misuse of opioids. The number of women with opioid-related diagnosis documented at delivery has increased by approximately 131%, and a lot of these are pre-pandemic numbers. Next slide. So we're going to have a twofold discussion today, and what we've gotten from our other feedback, people love the information, but they also needed to be grounded a little more in an understanding of how it affects the developing brain. So one thing I want to talk about a bit today is this really is a twofold discussion. One, when we're talking about neonatal opioid withdrawal syndrome or neonatal abstinence syndrome, we're talking about when babies are born, some of the immediate withdrawal effects of opioids. So if a mother is pregnant and taking opioids and the baby is constantly exposed to that, they are going to undergo withdrawal when they're born. And I'm going to talk a little bit about what that process looks like. But then I'm also going to talk today about some of the long-term impacts on brain development, some of which you might be seeing of children that come into your care or that you're providing support. So one, I'm going to talk about the immediate need. I hope that makes sense. But then I'm also going to talk about what the research says around what some of these long-term developmental impacts that schools are seeing. Next slide. So neonatal opioid withdrawal syndrome, it's the sudden discontinuation of fetal exposure to substances, in this case, opioids that were used by the mother during pregnancy. Next slide. So I am relying on video a lot today, so my voice can work okay. I hope it also varies it up a little bit from me and my gravelly voice. This is an excellent video on some of the care, and I'm going to talk more about this, some of what some of these hospital NICUs, these neonatal intensive care units, are seeing with children exposed to opioids, and some of the care and supports that they give, the early intervention that they give to these babies in the hospital. The video was done in Tennessee, so you will hear an accent that doesn't sound like Minnesota. There is not a Minnesota-made video, but I think it does a beautiful job of describing what hospitals are seeing with children born, as well as some of the care tools, as well as some of the people that are there as volunteers that get to rock the babies and cuddle and cradle the babies. I think that would be a wonderful job. I will tell you, this was a promotional video. I want to be very honest about that for this department. So I'm going to stop it before it gets a little bit too much into the promotion. But it has a lot of good information up until that point. So Drake, I'm going to have you play it, and I hope we can hear it. He's getting the captions set up. Sorry, it's a little putsy, but it'll be worth it.
For infants that come into the world dependent on drugs, life is a rough start.
They sometimes have this loud, piercing cry in spite of everything that is being done for them. These babies are also very jittery, very irritable, difficult to console just by holding. Their respiratory system can be affected. They may breathe fast. Their gastrointestinal system may be affected. They don't do well with feedings. They may have vomiting and diarrhea related to their withdrawal.
Neonatal Abstinence Syndrome is where an infant is in utero, exposed to medications that can be prescribed or not prescribed. The infant, when delivered, has to withdraw from those, just like a mother has to withdraw. Depending on the medication, we have to provide medicines to help that patient or that infant withdraw slowly.
Unfortunately, weaning infants off those drugs has become a growing concern in Tennessee.
We are really in the epicenter of the problem within the United States. It's very centralized in Appalachia, though it is spreading across the United States.
In 2010, as the number of babies with NAS increased, the doctors and nurses at East Tennessee Children's Hospital discovered they were dealing with an epidemic that had no established medical protocols. So they created them. With an innovative care regimen that included a specialized NICU that minimized light and sound, a comprehensive system that scored symptoms, and one very hands-on calming technique.
It's the job of the cuddler to come in and hold them, rock them, and try to get them back to sleep. I like to talk to them and I tell stories. My singing is kind of bad and they fall asleep to that. Sometimes my yoga breathing puts them to sleep.
Blue Cross was the source of comfort as well.
Thank you so much. I don't know about you, but I think I would love in my retirement to be a volunteer cuddler. I think that would be one of the best jobs that there are out there, right? So yeah, that's what we were saying, some of the calming techniques. I'm going to talk a little bit about some of these symptoms that are seen in these NICUs with the babies going through withdrawal. Next slide, please. So symptoms, and I think, Drake, if you can you put the acronym for Neonatal Opioid Withdrawal Syndrome, just because from here on out, I'm going to say NOWS as a shorthand. But what we are seeing reported in neonatal units with the babies that are born is a lot of irritability. So when these babies come out, they're used to this steady supply of opioids, and we see a lot of dysregulation in their central nervous system. We saw that in the video. So things such as a high-pitched cry. I don't know if we could hear that in the video, but it's a very notable high-pitched cry. A lot of irritability, hypertonia, stiff muscles, hyperreflexia, these stiff reflexes, difficulty sleeping, and difficulty being consoled. And we were seeing that in the video, hence the job of the volunteer cuddler. We also see a lot of gastrointestinal or GI distress. So these babies will have a disorganized swallow-suck reflex. They'll have a very hard time with it. Poor feeding, weight loss, we'll see loose stools or diarrhea, and a lot of spitting up. Now, anyone who's ever met a baby, a newborn baby, they do a fair share of spitting up, but this is well beyond that. We see a lot of, again, dysregulation in their autonomic nervous system, hyperthermia. They have a very difficult time regulating their temperature. Their system's out of sync. I mean, really, if that's the big takeaway that you can think about. We see nasal stuffiness, sweating, the sneezing, frequent sneezing, mottling, yawning, and just a lot of stiffness motor-wise. Next slide, please. We also, I think it's helpful for us to know that as the baby's brain, as their system's going with withdrawal, the lack of opioids to an addicted brain alters the neurotransmitters. And neurotransmitters, simply stated, we've all heard of them. These are these chemical messengers from brain cell to brain cell. They talked in the video about dopamine. That's our alertness. When we drink a cup of coffee in the morning, how many of you need that jolt of coffee? Show me, you can just raise your hands. Your dopamine, it helps you focus. It increases that seeking behavior. So a baby that's been exposed and no longer is provided dopamine decrease. So that leads to that hyperirritability and anxiety. Just trying to talk about what we're seeing in the brain, what sort of biochemical, neurologically, what we're seeing around that. We see a decrease in serotonin. One thing about opioids, not only do they help with pain, but they give you a feeling of euphoria. It's interesting. We're going to have a speaker later on who talks about they really have not been able to disentangle the pain relief effects with the high, the euphoria. And that is why people, even beyond the pain, continue to take these opioids. So in these babies going through withdrawal, we see the serotonin decrease. So their sleep is affected. Serotonin helps regulate sleep. When someone goes on an SSRI, selective serotonin reuptake inhibitor, it often helps with regulate their sleep. And so these babies are seeing a decrease in their serotonin. And so the architecture of their sleep changes. They can't sleep very well. They wake up a lot. Acetylcholine, feel energized by that. And it also, when it increases the stress, we're seeing things GI. Those are those GI symptoms we're seeing. So diarrhea, vomiting, yawning, sneezing, sweating. And then noradrenaline increase. We're seeing that in their brain. So that's around the temperature. They see hyperthermia, increased blood pressure, hypertension, tremors, and tachycardia. So these babies are going through a lot. They are really uncomfortable. And again, that is why in the video, we were seeing a lot of people soothing those babies. Next slide. So again, that was a very brief, because we don't have a lot of time, sort of overview of some of the interventions right away to deal with that withdrawal, to comfort these babies, to help them feel comfortable. Now I'm going to sort of pivot really quickly to some of what is happening to the brain development, because the exposure of opioids to the developing brain, research is saying we're seeing some long-term outcomes around development. So we do know, and all of you are early, not all of you, many of you are early intervention providers, right? And one of the reasons we do that is a baby's brain during that birth through 3, or a toddler's brain birth through 5. It's really malleable, right? A lot of what we do can affect their development in positive ways. But we also know changes of the brain can occur in response to substances and exposure, not just opioids, but really any substance, right? Next slide. So we know, this is what I was saying earlier, the fact that the baby's brain is looking for input and is ready to respond. It's a great time for early intervention. We know programs like WIC support nutrition. The work you do supports healthy brain development. The fact that their brain is plastic at that time, there's a lot we can do. But next slide. As I was saying before, it also makes babies and babies' brains remarkably vulnerable to insults, right? To insults, it could be a virus, it could be alcohol, it could be smoking, it could be drugs such as opioids. So this is why we really want to understand better and intervene early for children that have been exposed to opioids or really any substance early. Next slide. So effect on brain development. Some things that we know, and I'm being very general here, and then I'm going to go sort of through these developmental windows. But what we know, what the research tells us, how globally, how opioids affect the brain, can often affect the visual center of the brain and the retina. We're also seeing long-term impacts. We're seeing poor inhibition. You know, when we think about some of these kids, they can't inhibit response. We may see impulsive behaviors. We see deficits in working memory. An abnormal sense of body and space, that proprioceptive input. A lot of these children just can't really get a good sense of where their body is in space, maybe bumping into people, you know, not really a sense. You know, I know that if someone's next to me, I can't flail my arm, right? It's going to hit them in the head and that won't be good. We're seeing some of these kids combining that with impulsive behavior. It's really problematic. And then abnormal attention and learning. This also looks a lot like ADHD, right? And so definitely I'm going to talk a little bit later about, we're seeing a lot of co-occurring ADHD with these children. Next slide. But it's not as easy. Research is never as easy as we want it to be. And one piece that is very hard in providing good research on children who've been exposed to opioids prenatally is there's a lot of developmental confounders, and I'm going to walk us through this. One, often the moms are polysubstance users. What does that mean? Well, often it's not just opioids. It may be opioids, alcohol, tobacco, marijuana, you know, and so we're seeing multiple substances and the interaction effects with those. So as I go in as a researcher, it's very hard for me to isolate that variable. And I want a full disclosure. I research developmental delays. I don't specifically do a lot of research in the space of nows. but I certainly understand the research when I read it because I work in that. A lot of kids who've been exposed, the pregnancy is not necessarily healthy. Maybe the mom hasn't had good prenatal care, good nutrition, so they're at greater risk of prematurity. Well, we also know being born early, having low birth weight is also highly associated with developmental delays. So you're seeing it's not as easy to look at these children through a research lens as we'd hope because they have multiple risk factors. Would that fit? I guess show me with a nod of heads with some of the kids with whom you've worked with that have had prenatal exposure to substances. Has it often been multiple risk factors? I'm seeing people raise their hands. Then we also factor in socioeconomics, poverty, parent mental health and addiction, and then also family genetics. So it's very uncommon, I'll just be honest, for children to only have had prenatal opioid exposure as their only risk factor, if that makes sense. So we have to look at all of these risk factors globally. Next slide. Also, we need to think about the impact of trauma when we're thinking about working with these kids, but also through the lens of research. So childhood trauma and signs of its impact on young children. So we're thinking of all these other risk factors these children may have, such as physical abuse, possible neglect, maybe there's domestic violence, substance use. All of these, you're seeing these are the ACEs, the adverse childhood experiences. And we see all of those also sort of converge on some of these characteristics we're seeing in this population, such as regulation issues, sleeping and eating, increased anxiety, aggression, and hyperactivity. I'm just trying to paint how challenging this landscape is. I know many, if not all of you, work with families. You're said, welcome to my world. Working with families has a lot of challenges and a lot of what we call as researchers multifactorial inputs. But you know, children, families come with a lot of strengths, but also a lot of challenges, right? And we work with them the best that we can. We say that the same way clinically. Next slide, please. Sadly, the research also tells us there's attachment issues, greater risk of attachment issues. You think about a child, if a parent is dealing with mental health issues, addiction, what we're seeing here is that classic attachment gaze between a caregiver and a child. You think if a parent is significantly depressed or addicted, they may not be in a position to provide high quality care. They love their children. I am not here to say anything different, and many of them want to do a very good job, but addiction is a powerful thing. And so we also were seeing a lot of challenges around attachment around that as well. I'm going to give you some specific research in just a bit. Unfortunately, my voice is becoming increasingly more like a frog. Drake is going to take over if that happens, but I'm going to keep pushing through. He looks a little frightened, but I'll keep going. And development, we see a lot of, again, as I said before, effects on fear and anxiety, greater risk of anxiety. I'm looking at these symptoms globally, and then I'm going to go kind of through developmental stages. Abnormal muscle tone and movement, we're seeing that generally in the population of children with prenatal exposure, and then that abnormal GI reflex. Next slide. So research on long-term effects. I know I already pointed out some of the challenges, but we know that there's more studies needed. We need to follow kids from birth all the way into adulthood, into young adulthood, and maybe beyond to understand. Like prematurity, issues do not resolve with infancy. In children that are prenatally exposed, we're seeing it throughout the developmental cycle. We're also seeing long-term effects and frankly costs to society. Lifestyle, economic, genetic, and social issues surrounding development needs need to be considered, and support may be needed throughout young adulthood and possibly throughout the lifespan. Next slide, Drake. Another risk factor we're seeing right after birth, these are odds ratios. And so if you see an odds ratio of 1.87, almost 2, children prenatally exposed to opioids are almost 2 times more likely to have low birth weight for age. For those of you that do early identification in Part C and Part B, we know low birth weight is an auto-qualifier, right? Fun fact, maybe not a fun fact, but a fact, there are some states that neonatal exposure to substances is an auto-qualifier, not Minnesota. But that alone, if it's documented in the records, is an auto-qualifier. For example, I believe Ohio is a state that if a child's been prenatally exposed to opioids, they automatically qualify for Part C. We also know prematurity. There's that one. Children that are prenatally exposed to opioids are about 50% more likely to be born premature. Next slide. And we know those two, prematurity and low birth weight, are interrelated. Not always, but often co-occur. So 0 to 6 months, developmental concerns. I'm going to take you, I'm a developmental psychologist. I work a lot in development. Those birth through 6 years, the children that we're seeing in Part C, some of the challenges that we see. Muscle tone, delayed motor is one of the presenting concerns. Torticollis, those are those stiff, the arms maybe stiff muscles. Sensory issues, crying, not sleeping, digestive issues, that high-pitched cry. For those that work in it, they know what it sounds. Difficult to soothe, decreased self-regulation, negative affect. We think about that in terms of that bidirectional relationship with attachment. Increased sensory seeking behaviors. They're dysregulated sensory-wise. So they're going to be seeking. They may be needing high sensory input or low. For infants in the withdrawal process, hypertonia can lead to exaggerated back arching as the body moves into extension. Swaddling and non-nutritive sucking can help decrease these pronounced and atypical body positions. We had on one of ours, we had a parent that did foster care with children with neonatal opioid exposure. And she did a lot of swaddle baths, warm swaddle baths, that she said was very comforting to some of her infants. Certainly, I'm not an expert in that. We could talk to Dr. Precker next week, but some of the soothing techniques with very, very young babies. You definitely would need some training in that, but that was something that she said was helpful to some of the babies. Next slide. Behavioral outcomes at 5 to 8 months. Exposed infants show decreases in self-regulation and increases in sensory seeking behavior. So we know development doesn't discretely change out, 0 to 6, this ends. We know there's overlap. We're seeing that. We said in the last one, the shorter the time to treatment of NAS, the higher the parental stress. So these babies need treatment early. We've also, some of the research says a longer hospital stay, the greater parent-child interaction dysfunction. Some states that are more ahead of Minnesota really are working on that. They know they can offer supports in the child, such as what we saw. Remember the volunteer cuddlers. For example, in that unit in Tennessee, they have nurse practitioners that are highly specialized in this. But they also know that the research says the longer they're in the hospital, the more challenging it is for that parent and child to bond. So it then further highlights the benefit or the value of services many of you are providing that go into babies' homes. There's supports in the hospital, but the longer the stay, the more difficult. I think because it's a stressful place for the parents. A lot of parents report they're feeling judged. It's not a great place often for moms and parents. Frankly, many of them may still be in the throes of addiction. And so that's also something we learn. How do we better support in clinical settings parents? Next slide. Developmental concerns, 6 to 12 months, where again, we're seeing that delayed motor development. That's going to stay through. Feeding issues, sleep problems, eye problems, hearing problems, these atypical motor patterns, fidgety movements, back arching, failure to use eye movements to predict another person's actions. We know that can have a cascade effect on development. Babies watch their caregiver. They make eye contact, well, typically with their caregiver. And if they're not able to do that and regulate eye contact, that can have outcomes, difficult developmental outcomes in terms of attachment, social communication. Next slide. Developmental concerns. Now we're getting into toddlerhood. So children with neonatal abstinence or neonatal opioid withdrawal syndrome, now these kids, they're no longer withdrawing, hopefully, but now we're seeing some of these more long-term developmental concerns. So speech language delay, that's a big one in general, right? All of you that work in early intervention know that that's typically our biggest referral. It's sort of a non-specific indicator of a lot of developmental delays and developmental disabilities, but in this population, we're certainly seeing a speech language delay. We're also seeing behaviors possibly related to sensory dysregulation, irritability, but increases in biting, head banging, sleep issues, and lower cognitive skills as measured on the Bailey. Next slide. Not all children. There certainly are some that thrive, right? When we look at numbers in aggregate, this is what we're seeing, but I think all of you can probably think of a child you've worked with that maybe was exposed and is thriving. We know there's individual differences, but in aggregate, these numbers all together, these are the impacts we're seeing. What we hear from that 2 years to to about 3 years to 24 to 36 months. It feels like to caregivers, this is a description we were seeing in the literature, can often feel like terrible two on steroids. Those aren't my words, but a lot of parents were reporting that it's well beyond the typical sort of terrible twos in toddlerhood. Inability to play with toys, or really to use toys in any type of functional manner. Always moving, sensory craving, hyperactivity, poor attention, poor sleep. There's that language development that is subsisting over time, as is the poor sleep and motor, tantrums and hyperactivity. Again, it can also look a lot like ADHD. For those of you that work with children, we know that ADHD, relatively common. It really is behavioral descriptors, and there are many pathways to ADHD. And so we would say that children prenatally exposed are at a greater risk for ADHD. Next slide. 3 to 5, the research tells us, again, we're seeing, it's interesting. We're seeing sort of the same themes, but a little more nuanced based on the developmental period. So age 3 to 5 years, we would presume a child has a little more language, but in children with neonatal or who are prenatally exposed to opioids, greater oppositional defiant issues. Again, that speech delay, poor attention, poor fine motor. So not only are we seeing the gross motor, but we're now seeing that emerge. The poor, I don't know if we have any OTs on the call, do we? I still say call on the Zoom, Drake, but now we're seeing that these children have a harder time with these fine motor tasks, but we're also seeing gross motor delays. So really a dysregulated motor system. Next slide. So a lot of this data, and if you want to look at it, look up the Boston birth cohort, which is a longitudinal study. I'm a researcher, so it makes my heart go pitter patter. There's longitudinal studies are studies that start with the cohorts and they follow them. They are very important, but also very expensive, therefore somewhat rare. And this Boston birth cohort, I need to look thousands and thousands and thousands of children followed from birth, I believe, into the teenage years, but this is birth through 6, and they did have a subsample of children who'd been exposed to opioids. And these are some of these odds ratios again. I think this is really fascinating. So stay with me, because I'm going to tell you a story that the data tells us. From birth through 6, ADHD, they really weren't, an odds ratio of 1.01 really means they were looking very similar at that point in terms of ADHD diagnosis to children who were not exposed to opioids prenatally. That said, a lot of you smart people may be saying, well, maybe that's because we typically don't diagnose. Sometimes we do, but it's not a common diagnosis under age 5. So that may be a bit of a confounder there. But in the cohort of birth through 6, they were over 2 times likely to have a diagnosis of conduct disorder or emotional disorder. Almost 2 times as likely to have abnormal physiological development. Next slide. So as we follow this cohort, the Boston birth cohort, this is the next group, 6 years of age. After 6 years of age, here now we're seeing that ADHD diagnosis come online, about 2.5 times more likely than children not exposed to opioids to have a diagnosis of ADHD. I need to see that number. It's blocking on my screen. Does that say 1.79, Drake? On the slide, again, almost 2 times as likely, a little under it, conduct disorder or emotional disorder, and then that abnormal physiological development. Drake, can you read that number to me? I have a block on my screen. 1.62?
0.62.
Oh, okay. So
sorry,
actually,
that's cut off.
That's okay. That was actually a little bit lower then. So we're seeing that they're catching up a little bit with some of those motor pieces. But what we're really seeing in this 6 years of age and over are these attention, impulsivity, lack of inhibition, the ability to kind of control. I mean, you think of how many of you have a child in your class that just blurts out? They have no ability to inhibit response. Maybe they're excited about the lesson, great, but it's like, can you wait? Just don't blurt it out. Lack of inhibition. Some of that's developmental, but we're seeing significant issues around that in this population, as well as conduct and emotional disorder. Next slide. Just in the interest of time, you know what, we'll send out the slides. I'm gonna skip this one, Drake. I'm not sure how much longer my voice is gonna hold up. One piece, I want you to have resources, not just information, but resources. I'm going to encourage all of you. There's a campaign I work on, and it's not just about opioids, but it is a campaign with loads of free developmental materials and free resources that helps us support parents that may have children with developmental delays, monitor as well as support childcare providers and healthcare providers. Please, when you're done, not now, because then you won't pay attention to me, please Google CDC's Learn the Signs, Act Early. It is a wealth of free materials. And then look at the free materials. You can get storybooks, you can get on healthy child development, monitoring tools, you can get trainings with free CEUs for early intervention providers about talking about developmental delays. Simply stated, children who are prenatally exposed to opioids or any substance are at a much greater risk of having a developmental delay. So it is a population we need to pay close attention to. Next slide. They have all kinds of developmental checklists. All of these have paper formats, but because we're in the year 2022, they have online tools, checklists parents can use to monitor development, not just parents, but childcare providers, anyone, healthcare providers. I'm going to trust all of you are going to follow up and see all the free materials we can give you. Next slide. One of which, how many of you have seen these materials around the state? They're free storybooks. They're beautifully done. Where is Bear? Amazing Me, Baby's Busy Day. You may be like, why? This is about opioids. Why are you showing me storybooks? They are free. You can get them within our state. Please reach out to Drake if you want to get them within Minnesota, but also I encourage you to visit CDC website. They take a journey of development, Baby's Busy Day, what you would expect a 1-year-old to be doing. It has little milestones. It gives parents, but it's not done in a too didactic or teaching way. It's a really enjoyable book for parents to read with children, and developmental activities and how you can talk to your pediatrician if you have concerns. Whereas Bears for 2-year-olds and Amazing Me 3, It's Busy Being 3 is all about what we would expect in development via a story that a parent can read with their child. What you expect and how to act early if there are concerns. Trust me, these books are wonderful. So reach out to us. I think they are out of stock at the CDC right now because they're so popular. You used to be able to order lots. I will tell you, some early intervention providers give them to families at the Screen at 3 or some Screen at 3 programs, literacy nights, parent conferences. They are wonderful. Check on the CDC website if you can order them, or reach out to us and we'll help try the best we can help get you a supply of those. They are wonderful tools. Next slide. We also have a tracker app. I encourage you to take a look at that, download it. It's free, no advertising. You can track, you can put it in your whole class if you're an early intervention provider and track their development. It gives you tools. We want you to have tangible tools. This isn't just about children who've been exposed to opioids, but it does help provide supports for children that are at risk for developmental delays. Next slide. So here are my references and resources. That was all the research that I shared with you about some of the characteristics that we see in children exposed to opioids. Now, I think I moved through it at a pretty good clip. We're going to share a family story. And because my voice is really giving out on me, I'm not going to sing a song. That would be terrible. My goal is to make it to the end. We want to share this via video. It is a parent telling about her story about prenatal. She did use opioids while she was pregnant. I want to be clear, no one is here to demonize parents. You're going to hear a little about her story and how she got in a position of using opioids while pregnant. She also was one of the lucky ones that was well connected into services and supports right when her child was born. It'll be a video and we'll play, and then we're going to talk through it and then let you go into small groups. So I'm going to have Drake play the video. And I think it has good sound quality, but let us know if you can't. We always want to set up the closed caption, so that is why it takes us just a little bit. And her son is just cute as a button. So cute. And the sound will be coming on in just a second. Video is a great tool, but it's a little hard.
It's time for me to.
It's been a long road for Melinda Markham and her young son, Michael. She started taking opioids in 2012 after her daughter was diagnosed with cancer. The pain pills progressed to heroin. Eventually, Melinda stopped, but then started again after the death of her daughter at the age of 5.
It was like the worst it had ever been. I didn't realize I was pregnant until March. So from December until March, I was using.
Melinda eventually went into detox, where she was given buprenorphine, an opioid medication used to treat opioid addiction. In June, homeless, she showed up at First Step Home in Cincinnati, a residential treatment center where women live with their children as they recover from substance abuse.
Reality hits, and you know, that you're the reason that's happening.
The opioid epidemic doesn't just touch adults. Michael was born in withdrawal and spent a month in newborn intensive care. His withdrawal symptoms were strong, and he eventually went home on a prescription to ease the muscle tightness, jitteriness, and inability to be comforted. Today, DeMichael is a patient at the Neonatal Abstinence Syndrome, or NAS, follow-up clinic at Cincinnati Children's.
There's that smile I've been waiting for.
Gail Hertenstein is DeMichael's nurse practitioner at the clinic.
Melinda keeps all of her appointments. We keep close tabs on him. He is meeting his developmental milestones, and he's doing great. He's doing great.
The NAS clinic provides developmental screening, occupational and physical therapy, and education about nutrition and feeding. As the babies become toddlers, they are evaluated for language and communication, behavioral issues, and overall development.
The long-term implications for, opiate exposure are still unknown. This clinic, to my knowledge, is one of the few nationwide that we have.
Everybody's talking about the heroin epidemic, but everybody's talking about the addicts. It was talking about the overdoses. And where were the children left in all of this? And if we don't address the children, then this is just going to go on.
Unfortunately, business is booming. In 2016, about 4% of babies were exposed to opioids in utero. When a baby needs treatment for withdrawal, the average length of stay in newborn intensive care is 16 to 18 days. And nationally, the average cost is $66,000.
Parental addiction is a very disruptive situation, and the child should not have to suffer because of that.
Each year, as many as 12,000 babies in the United States are born with fetal alcohol syndrome, and the results are devastating. Whether the same will be true for those babies born with NAS is something the clinic will be studying. In the meantime, the clinic is doing its best to get families help as early as possible.
Today is the 3rd. I had my son on the 3rd. I got clean on the 3rd. I am 8 months clean today. It works. It really does work. And it's such a better way of living.
All right. I think that's a nice video. And it presents the complexities. Parents often get in situations that no one says that they want to use opioids while they're pregnant. And the mother in the story had quite a bit of trauma in her life, and wanted to do better, right? So next slide. I know it's hard to pull out of the video. Drake, sorry. Drake is being a trooper. So Melinda, back one. Background. So we had Melinda and her son, DeMichael. I'm just giving you a little background because you're going to talk in small groups. DeMichael is 8 months old and was born with neonatal abstinence syndrome. As the video said, Melinda began using opioids when her daughter was diagnosed with cancer, stopped briefly, but started again after her daughter passed away at age 5, a significant trauma in her life. She moved from opioids to heroin during pregnancy. That's not uncommon. A common pathway we often hear is someone starts on opioids for a surgery. So, name your surgery, something as common as wisdom teeth surgery. They are changing practices that are not as commonly prescribing those for relatively minor surgery. But someone starts on opioids, becomes addicted, possibly moves to street heroin, possibly fentanyl. Right now, I'm on another echo with medical providers. Their concern is actually the polysubstance around possible methamphetamine and opioids, but that I'm diverging from the family story. Get back to it, Jennifer, right? Melinda sought treatment help once she learned she was pregnant. So she did use while she was pregnant, but went into treatment right away. So these are strengths and challenges she brings from her background. That's probably not uncommon to families with whom you work. Her strengths, she went for help. She found a center to stay in with her son while in recovery. So she's in a center, not a hospital. She keeps all of her appointments. These are strengths. We know families bring strengths and challenges, right? And we're going to challenge ourselves. I have yet to meet a family that doesn't bring strengths as well as challenges, right? And we need to acknowledge that as well. And she's in recovery for 8 months. I'm very, very proud of that. Recovery is hard work, day by day, every day. And she's trying. But challenges, she's had significant trauma in her background, her daughter's illness and death, homelessness, poverty, lack of education. There still is a lot of uncertainty in their future after she leaves the recovery center. I may be losing my voice, Drake. Relapse is amazingly common in opioid use, and mothers report they feel very judged. They feel judged in labor and delivery, and sometimes they don't, but overall what we hear in aggregate, they feel judged, they feel embarrassed, and they also feel clinicians often maybe judging them. Drake, I think I'm going to turn it over to you to start the cruise.
Yep, no problem. Like Dr. Hall-Lande had mentioned, there's some background, and we've got our strengths and our challenges. So now, as we move forward, we just have some breakout questions for the group. We'll probably be splitting you up into groups of 4 to 5, so you can have some discussion. And our questions are just, how might Melinda and her son be better supported right now to prepare the family for leaving the recovery center? So think about, how they can best be supported. And then, what would you suggest the state, county, or city could do to support them and connect them with for their future departure? So kind of, what services do you think they could be connected with? So